Today's talks are not only timely during this COVID-19 pandemic, but also important in the clinical care we provide our patients. I will be speaking on retinal toxicity from plaquenil, and Dr. Aguilar will be discussing the current Vrsp advisory among COVID-19 patients. Hydroxychloroquine is an established and long recognized retinal disorder. It is described in textbook as the classic bullseye maculopathy. However, I will be discussing retinal toxicity in the context of modern retinal imaging and how visual loss can be readily avoided in our patients. Hydroxychloroquine or plaquenil is a chloroquine derivative. It is used in the treatment of malaria, rheumatoid arthritis, SLE, and other rheumatologic conditions. With proper screening, severe retinopathy, described as a bullseye maculopathy, should no longer be seen. Retinal toxicity from hydroxychloroquine results in irreversible and progressive visual loss even if the medications are stopped. This emphasizes the need for ophthalmologists to be aware of potential ocular side effects. The screening guidelines have been established by the American Academy of Ophthalmology in 2012 and updated in 2016. However, clinical practice has been reported to be inconsistent or deficient. The mechanism of toxicity is still not fully elucidated. The drug affects the metabolism of retinal cells. It binds to melanin in the RPE, and this explains persistent toxicity after discontinuation of the medication. In clinical practice, the primary damage is to the photoreceptors, and as the outer nuclear layer degenerates, there is secondary disruption of the RPE. Early in the disease, there are no symptoms. In a vast majority of patients, patients may report trouble with reading or diminished color vision, but this is rare. Later in the disease, patients lose central acuity, peripheral vision, and night vision due to damage to the photoreceptors and RPE. Similarly, there are no clinically evident visible fundus changes in early disease. Visual fields, autofluorescence, spectral domain OCT, and multifocal ERG changes can be detected early, emphasizing the need for these functional and structural imaging tests to detect early changes. Late changes include bilateral changes in the RPE and the typical bullseye maculopathy. The most important factor for retinal toxicity is dosage. Cumulative dosage may be a more important consideration than daily dosage. Higher daily dosages will lead to the toxic cumulative dose more rapidly. This similarly leads to a higher concentration of the drug in the RPE and more aggressive tissue damage. Cumulative dosage calculators are available online and should be used. Typical daily dosages is between 200 to 400 milligrams per day. High-risk characteristics for toxicity include a daily dose greater than 400 milligrams, daily dosages over 5.5 milligrams per kilogram of real body weight, total cumulative dose of more than 1,000 grams, medication use longer than 5 years, concomitant renal or liver disease because the drug is cleared by both routes, underlying retinal disease or maculopathy, and tamoxifen use. Earlier and more frequent screening is necessary for those at higher risk for toxicity. Given the real risk for retinal toxicity among patients on long-term use, early recognition of retinopathy prior to the appearance of RPE damage may limit progression after discontinuing the medication and avoid significant visual loss. Monitoring is recommended within the first year of starting the drug, with subsequent examinations after 5 years or sooner based on the need. hamster grid, color vision testing, and full field ERG or EOGs are not recommended for screening. Fluorescein angiography may visualize early subtle changes in the RPE, but it is not considered a screening tool for retinal toxicity. Pre-existing disease may interfere with the interpretation of screening tests. Hence, the use of color fundus photographs to document changes or pre-existing retinal pathology. A dilated fundus exam should not be considered a screening tool since it identifies toxic changes late. A critical component of screening is the counseling of patients on the benefits and limitations of screening. This includes the importance of routine monitoring, identifying toxicity at early stages, and minimizing visual loss. Working with the patient and the rest of the healthcare team, the goal of screening for retinopathy is not to stop valuable drugs at the first borderline abnormality, but to recognize definitive signs of toxicity at an early enough stage to prevent loss of visual acuity. The baseline examination should include an ocular examination documenting any pre-existing condition, and a Humphrey visual field white-on-white perimetry, 10-2 for white or Caucasians and 30-2 for Asians. At least one of the following objective tests is recommended, particularly if there is an underlying retinal or macular pathology. Toxicity is rare within the first 5 years of treatment. Ancillary testing is not necessary unless abnormalities are noted on baseline examination. After 5 years of treatment, annual screening is recommended, and this primarily includes visual fields and spectral domain OCT. Depending on the clinical need and availability, multifocal ERGs and fundus autofluorescence may be added. The following principles provide guidance on identifying retinal toxicity. Visual fields should be repeated promptly if changes are present. Objective structural imaging should be performed to confirm visual field changes. And more frequent and detailed examinations are required if retinal toxicity is suspected. This slide shows fundus photographs of patients with varying degrees of retinal toxicity. The patients with early and moderate toxicity on the top and middle rows have normal fundus findings, whereas those with severe toxicity in the bottom row show bullseye RPE atrophy. This slide shows the corresponding fundus autofluorescence images of the earlier patients. Of patients with early toxicity, patients E2 and E3 show an increase in fluorescence. Patients with moderate and severe toxicity show a ring of increased fluorescence and parafoveal dark areas representing retinal pigment epithelial loss. The flying saucer sign has been frequently described in cases of chloroquine or hydroxycholoroquine toxicity. This is a result of parafoveal thinning and the loss of the ellipsoid zone with preservation of the foveal architecture. On spectral domain imaging, this is demonstrated by foveal thinning of the ellipsoidal layer and outer retina with a preserved central fovea. Magnified spectral domain OCT cross-section scans illustrate the early signs of damage. The open arrows show the end of the inner segment outer segment line, and the closed arrows show the end of the cone outer segment tip line, which seems to disappear even earlier. These images are from the 2016 AAO guidelines. Image A is a normal eye. Image B shows early damage with a temporal SDOCT thinning and mild field loss. Image C shows moderate damage with no fundus changes or RPE pigment loss, but more severe SDOCT and visual field changes. Image D shows severe retinopathy with a prominent bull's-eye macular lesion, RPE damage on SDOCT, and a dense ring scotoma. These are clinical images from a 42-year-old Asian woman on 8 milligrams per kilogram per day for 8 years and 4 milligrams per kilogram per day for 2 years. Her 30-2 fields show a partial ring scotoma outside the parafoveal lesions. The multifocal ERG shows signal weakness most striking in an extramacular responses. Correspondingly, the autofluorescent image show increased autofluorescence near the arcades and decreased autofluorescence that signals early RPE loss more peripherally. This is reflected in the SDOCT showing marked loss of the outer nuclear layer in the ellipsoidal zone corresponding to the increased autofluorescence and beginning RPE disruption at the outer edge of the scan. As you can see, there is no parafoveal damage. These implications for systemic care is that once definitive signs of retinopathy are recognized, the decision to stop medication should be made in conjunction with the patient and the prescribing medical physician to ensure that medical risks are managed appropriately. The patient can be advised about the risk for further visual loss depending on the severity of retinopathy. To conclude, current screening techniques will detect retinal toxicity before there is any significant visual loss. The classic bull's-eye maculopathy should never be seen with appropriate screening. All ophthalmologists, but especially retina specialists, should be aware of the current screening guidelines to provide the latest standard of care to their patients. Thank you for your attention.
I've been tasked to present the Vrsp advisory on the use of hydroxychloroquine and chloroquine in the treatment of COVID patients. Before I proceed, let me thank the Vrsp for their continued trust and confidence in me, and for giving me this opportunity. Well, I hope that most, if not all of you, have received and read the advisory which was sent to you by email. If so, this may well just serve as a review. If you have any questions, please type them in the comment section and I'll try to answer them as we go through the lecture. Now, this is the paper that started it all. It is a French paper that appeared to be a breakthrough in the treatment of COVID-19, reporting a high percentage of recoveries among patients receiving hydroxychloroquine and azithromycin. Of course, the paper is now under intense scrutiny, but it has given birth to clinical trials, the results of which we eagerly await. Let's go to the rationale behind formulating this advisory. When in the morning of March 16, one day after the enhanced community quarantine was implemented, I received a call from no less than our beautiful VRSP President, Dr. Joanne Loy, asking me to formulate an advisory for VRSP. The main concern then was whether we, ophthalmologists, should be called in to do retinal screening prior to the initiation of hydroxychloroquine or chloroquine therapy. For this purpose, VRSP created a working group composed of Dr. Paulo Silva, Dr. Recival Saloncay, Dr. Cheryl Arsinue, Dr. Franz Cruz, Dr. Rorigo, and myself. At this point, allow me to thank the team for their effort and contributions. To Paulo, Resi, Shai, Franz, and Rory, thank you very, very much. To continue, in addition to what was dictated upon us, the working group decided to approach the issue with a wider perspective. We looked at the disease as a spectrum and therefore identified three target populations. First, we have the non-infected people, or maybe infected but asymptomatic. Next, we have the patients in the acute phase of the disease. Then, last, the survivors who are convalescing. Thus, we expanded the advisory to include other healthcare professionals, specifically the attending physicians who have the tendency to refer to us. We also added other issues like prophylaxis, recommendations applicable to the acute phase, and recommendations covering the period of convalescence. Our challenge was to balance not only the duties and responsibilities, but more importantly, in the face of the contagious nature of COVID, the health and well-being of the ophthalmologist, vis-a-vis the rights and well-being of the patient, using, of course, the best available evidence. To start off, let us talk about prophylaxis. It is well documented that chloroquine and hydroxychloroquine cause serious cardiac and retinal adverse events. Our previous speaker has made a beautiful presentation on this. We also know, however, that the use of hydroxychloroquine or chloroquine in COVID therapy is largely empirical and is supported by weak evidence. Herein we apply the fundamental tenet of the practice of medicine, primum non nocere, or above all, do no harm. Thus, our first advisory is not to use hydroxychloroquine or chloroquine prophylactically. Now, going to the acutely ill patient, here is the treatment algorithm recommended by the Philippine Society of Microbiology and Infectious Disease, or PISMID. When indicated, chloroquine is given at 500 milligrams twice a day for 10 days. Hydroxychloroquine is given at 200 milligrams, 2 tablets twice a day on day 1, then 1 tablet twice a day for 9 days. The total chloroquine dose comes to about 10,000 milligrams or 10 grams in 10 days, while the total hydroxychloroquine dose is around 4,400 milligrams or 4.4 grams in 10 days. Hydroxychloroquine is a derivative of chloroquine. As early as 1983, it has been found to be 40% less toxic than chloroquine in animals. A similar profile has been seen in humans. Table 2 shows in the left column the recommended daily dose of hydroxychloroquine and chloroquine that is associated with the lowest risk of retinal toxicity, which is less than 5 milligrams per kilo body weight for hydroxychloroquine and less than 2.3 milligrams per kilo body weight for chloroquine. The column on the right shows the estimated dose per kilogram body weight of the PISMID recommendations using a 60 kilogram individual. As you can see, the PISMID dose of hydroxychloroquine is 7.3 milligrams per kilo body weight, which is about 1.5 times the recommended daily dose. More frightening is the chloroquine dose of 16.7 mg per kilo body weight, because this is 7.3 times the so-called safe dose. This by itself raises a red flag. Seen another way, if we are to achieve the recommended less than 5 mg per kilogram body weight dose of hydroxychloroquine, the patient should be around 88 kilograms or 193 pounds. This is not entirely impossible. I know of some people who weigh that much. But for chloroquine, to achieve a safe dose of less than 2.3 mg per kilo body weight, the patient should weigh 436 kilograms or 960 pounds, almost an impossibility in our population. So, hydroxychloroquine or chloroquine? We advise hydroxychloroquine. Now, should we perform eye examination prior to the initiation of hydroxychloroquine or chloroquine therapy? Table 1 shows us the risk of retinopathy as a function of the dose and duration of intake. As one will see, at the recommended dose of 4 to 5 milligrams per kilo per day, the risk is less than 1%. The risk may be much less for doses less than 4 milligrams and may be a little bit higher for doses more than 5 milligrams, but data is unavailable. There is also no data for intake duration less than 5 years, but it may be safe to assume that this would likely be very low. But what if the dose used was more than the recommended 5 milligrams per kilo per day? Table 3 shows two studies wherein the dose range from 11.5 milligrams per kilo per day to as high as 20 milligrams per kilo per day. And this was taken over several months, and the onset of retinal manifestations was anywhere from 6 to 11 months at its earliest. This goes to show that even at relatively large doses, retinal toxicity does not manifest immediately. So let us review the premises. First, hydroxychloroquine or chloroquine retinopathy has an insidious onset involving long-term use. Based on this, the American Academy and the Royal College of Ophthalmologists recommended that initial eye exam be done within the first year of treatment, not necessarily prior to the initiation of treatment. We also know now that hydroxychloroquine and chloroquine is only given for 10 days in COVID patients, and that there is so far no evidence of retinal toxicity associated with a very short duration of treatment. Therefore, since data is insufficient, we recommended that ophthalmic evaluation prior to initiating hydroxychloroquine or chloroquine therapy is not necessary. This advisory becomes even more important and relevant when we take the contagious nature of COVID-19 into consideration for the welfare of our colleagues. Nonetheless, even if prior eye examination is not deemed necessary, it is still advised that patients be fully informed of the risk. Also, the presence of known risk factors to retinal toxicity should be investigated, namely renal disease, use of tamoxifen, and pre-existing retinal or macular problems, all of which can be safely obtained through a good history. Current evidence tells us that the risk of developing retinal toxicity among COVID patients on hydroxychloroquine or chloroquine therapy is largely not known, but may be low. But what if the patient develops visual symptoms anyway? Do we recommend discontinuation of the drugs because of a probable retinal problem? As far as this aspect is concerned, we chose life over sight. Our recommendation is similar to that of the Royal College of Ophthalmologists. Since the drug is potentially life-saving, we do not recommend discontinuation of the drug based on visual symptoms alone. Here we assume the patient survived and is recuperating. If visual symptoms persist, we recommend the proper eye examination at the proper time. Now, when is the proper time? The AAO and RCO recommend that baseline eye exam be done within the first year of therapy. But these guidelines may not be applicable to the present scenario. Nonetheless, it highlights the non-urgent nature of an eye exam. But because there are currently so many unknown factors, eye exam may have to be done within a reasonable time after recovery. So when is the proper time? Maybe a few months after recovery, but preferably, again looking after the well-being of our colleagues, when the patient is disease-free to minimize possible contagion. Continuing on, what would constitute proper evaluation? Proper evaluation should consist of a properly done fundus examination, visual field testing, and spectral domain OCT. As far as visual field tests are concerned, we distinguish between Asian and non-Asian patients. For Asian patients, the 24-2 or 30-2 protocols are recommended. For non-Asian patients, the 10-2 is used. SDOCT should preferably be wide field in an Asian patient. Optional exams include fundus autofluorescence and multifocal ERG if available. Herein is the summary of the Vrsp advisory. This should be in the document emailed to you by the PAO. First, prophylactic use is not advised. Second, hydroxychloroquine is preferred over chloroquine. Third, prior retinal screening is not necessary. Fourth, visual symptoms developing during therapy is not an indication for discontinuation of treatment. Fifth, persistent visual symptoms should be investigated when it is safe to do so. Finally, we want to reiterate that these recommendations were formulated from the current best available evidence, which involve long-term use of hydroxychloroquine or chloroquine in non-COVID patients. This will be updated when more evidence become available, particularly pertaining to COVID patients. Our references: for the PAO and Vrsp, I'd like to thank everyone who listened to today's lectures, wrote comments, and asked questions. And I'd also like to greet everyone a blessed and happy Easter. Let us all believe in the risen Lord and continue to pray for His blessing during this very difficult time. May all of us have a good day. Stay safe, stay at home. Thank you.